Okay, our next speaker on our last topic of the day is we threw everything at Tom at the end, and we said, okay, you're going to cover wounds and tissues and fluid cultures, and so he's got it all. So let's give a hand to Tom Novicki, who's going to be our last speaker.
Okay, thank you. I'm used to having the wireless and the walk around, so this is going to be tough for me to stand in one spot, but I'll do my best. So we're going to talk about wound, tissue, and fluid cultures, or WTF cultures. And, sometimes you look at them and you say, yeah, that's the thought that goes through your mind. But we'll try to get through it. Let's see, Okay. Couple disclaimers, nothing to disclose. We haven't used any, copyrighted images and so on and so forth. We're, very boring. And I actually do want to go back because I need to thank my co-presenters. Now, they're actually our co-contributors. They're not presenting, Alyssa Brenner and Megan Sell. And while they're not presenting, they did contribute significant parts to this, and so thanks to them as well. Okay. So the key points are these. Specimen collection transport is critical. And, a lot of what I'm going to say actually applies to all the culture types we're talking about now. But it's worth repeating them, especially in this particular arena where we get a lot of swabs, but we know those aren't the best. We're going to talk about the Gram stain. Is it worth doing? If it is, who does it help? And how could it be used? Culture workup and reporting. We want to aim for getting the maximal useful information without including extra information that may actually lead to overtreatment and confusing the results of the culture. And then talk a little bit about antimicrobial susceptibility testing. And then I also have a couple special topics at the end. Okay, so the keys to success are pre-analytical, analytical, and post-analytical, following details and doing it all right. Many of us have gotten into the laboratory profession because we don't want to deal with patients. We're just happy to be with our test tubes and culture plates. So it's easy to forget that, there's patients involved, right? And there's physicians, and they are our customers, but they're also our, they are also our colleagues in getting this all right. And so we don't think about these pre-analytical things. It's easy to forget them. But certainly, we have to make sure, we've already talked about this, the physicians and PAs and NPs, they are collecting cultures when it is appropriate to do so. When the pre-test probability is high that there's an infection, they want to collect it properly. The ordering is so important. Getting the ordering right, we're going to talk about that. Of course, the analytical part, that's what we're familiar with. And then the post-analytical, we'll talk a little bit about that. But it's as important, getting the information out, making sure it's used, making sure that the information is clear. These are all equally important, and we do it all right, we're going to have best patient outcomes. So let's talk about the pre-analytical. So I've been doing what I'm doing 20 years, and we basically had a homegrown computer system, and now we have Cerner. But we were in both cases, lucky enough to have two specimen source fields, basically the body site and the specimen type. And if you have that, and even if you have a single field, it's really important to think about what information is in that pick list. And don't just assume that whoever set the computer up did it right, because they probably didn't. I'll show you an example, a similar example in a moment. Because you want to get that information. It's important so that we can work the culture up, because we know what we're talking about. Superficial abdominal wound versus a abdominal abscess. Just as abdomen, we don't know. But it also helps the provider understand, and not just the one who ordered it and collected the sample, but everyone else who's looking at that EMR to say, oh, I know where that site is, where what was cultured. I want to be clear. We all know that the primary materials are best, the good stuff, the pus, the aspirate, the tissue. Swabs, we have to accept them. I'll talk a little bit more about swab and choice of swab in a moment. But I think as a best practice, anything you can do in your laboratory to discourage the use of swabs is better, because they're not as good as the actual primary material. Prepping the area, we've already talked about that with blood cultures, but that's certainly something to think about if there's going to be an aspirate taken, cleaning that site of the aspiration, it's very important. And then we want to minimize that plating time. Bacteria, fungi, microbes, they're living things, and they don't like being out of their environment that they just came out of. They were happily growing, lots of nutrients, they were good. Now they're taken out of that. So we say best practice is 4 hours, and maybe even as low as half an hour for fastidious. Now we know, obviously, in today's healthcare world, where we have satellite labs and outpatient clinics, we can't always do that, but you want to strive for that. And even if you have a lot of sites and you're a centralized lab, you might think about traveling incubators. We put that system in. It's worked out fairly well. We've got it down where the local lab, the collecting lab, does the plating, the initial incubation. They put it into this heated incubator, and then the courier brings it to us. So it's a seamless, it's as if, when it gets to us, and typically the timing is ready where we can start working on those cultures and even doing, the timing is right for susceptibility testing. So here's the screen of shame. This is, like I said, we switched to Cerner, and it was this big flurry, and no one consulted us, and it comes up, and then lo and behold, I happen to have taken a look. So this is what we have computerized physician order entry, CPOE. You may call it something different. This is what the physician sees when they search culture in our system. Duplicates, non-existent tests, placenta culture. I don't know where that came from. I mean, we would culture it, but we don't have a standalone test. So we're working to get that cleaned up. And one thing that I would point out, and your EMR may have the same thing, are these notepad icons. There's two different types, but you can populate that with relevant, important information. And so we want to flesh that out so that you can put anything, culture material, anything, what's the best practice, turnaround time, anything you want to put in there to help that provider and the people who are collecting the specimen do the right thing. Okay. Do you have a specimen collection manual? We call it a test reference manual. Now, the CAP requires that we have one, but how accurate is it and how accessible is it? When I came, our physicians would look at paper copies. I mean, some of you probably remember those, and maybe some of those still get used. Very difficult to control. You had obsolete copies. Now it's online. You want to make sure that that's accurate, that it has the information people need, and that it's in front of your providers. Where can they find it? Are they aware that it's there? We put ours right on the front page of our intranet in the section that physicians will look at for various bits of information. And this isn't pre-analytical, it's analytical, but that goes for policy and procedure manual too. You should really, have a procedure for everything you do, and make sure you follow it, make sure techs see it. We actually went and we put a second screen in at our workstations, and the techs have our document control system. It's up. and they can pull up the procedure. And then they have the electronic work card on the other screen. You know, it was not a huge investment. And it's, you know, it's there for everyone to use. Okay. I want to talk a little bit about rejection criteria. You know, no one likes to have to pick up the phone and say, hey, you know what, this specimen was collected wrong. We're not going to do the test, we're rejecting it. But you know what, you really should. You do the patient a favor, and if the specimen is collected properly, if it's timed out, you shouldn't accept that. And I'll talk about exceptions to that in a moment. But certainly, I think it's really important in that test reference manual is to say, you know, what are your rejection criteria? You know, it wasn't refrigerated in transport. It was in the wrong specimen container. It's, you know, 4 days old. Now, you know, so make it clear what your rejection criteria are, and then enforce it. And if you have repeat offenders, you know, you or your manager or your lab director has a conversation with that provider. That said, there are exceptions, right? You know, if it was a surgically collected tissue, you know, and let's say they put it in a non-sterile container, for instance, you know, well, then, you know, the manager or the lab director or even the tech, if it's a, you know, more, you know, tech who's comfortable on the phone, say, you know, here's the situation, you know, it wasn't collected right, your call. Do you want us to culture it? You know, and you might do it, but then put in a comment saying, you know, this was a compromised specimen, you know, results may be, you know, compromised. So let's move on to the thing that we really do, and that's the analytical phase. So here's a question. Do you do direct gram stains on your wounded tissue fluids and specimens? So we'll start the polling. Okay. What, I kind of watch it till the counter slows down and then, yeah. Okay. It's pretty good? Okay. Okay. All right, yes. A few say no, and some have maybe a little more sophisticated algorithm, but the majority of people do. Okay. So, another one. Does your laboratory use that gram stain in the workup of the culture to guide how you process that culture? All right. All right. So yeah, most of you do. So that's very good information. I can say for us, you know, we do get a lot of swabs, and before we got the e-swab, which we switched to about 10 years ago, and I'll talk about the e-swab, but I think most of you probably know, or a flock swab, that facilitated, because it turns a swab sample into a liquid sample, you can do gram stains. Okay. So, you know, I think it's a valid question. Is it worth doing? You know, we have limited resources. You know, what does it contribute? It takes time, it takes resource. Well, there was a nice review here done last year, and it really looked at the use of routine gram staining and how it contributed, in this case, to antibiotic stewardship, antimicrobial stewardship. And you know, the bottom line was, yes, it's a value in doing and reporting gram stains. And how is it? Well, it's a value to the clinicians, obviously. You know, it's an early indicator. Is it a gram positive? Is it gram negative? Is it a fungus? And then it also helps us at the bench, you know. And you may always, you know, tech may pull it up all the time, or they may only use it in a difficult culture. But to have it there is really critical. And I already alluded to this, is the difference between the spun swab and the e-swab. You know, when we use the spun swab, the culture swab or culture swab plus, well, besides the fact that those type of swabs don't release most of what they absorb, we would require an extra one if you wanted a gram stain with a swab. Now, as I said, with the e-swab and similar products that use the flock swab and a liquid medium, is it turns it into a liquid sample. And so you don't need to get extra to do the gram stain. You just take a drop. And of course, the other good thing about the flock swab is it releases everything it's holding into that fluid. And also, in the case, if not, well, we don't gram stain urine, but in sputum and maybe in wound cultures and such, it informs us about things like PMNs being there, or maybe squamous epithelial cells, suggesting a more superficial specimen. Tissue processing. There's several options, and we know with the tissues, you just can't plunk it on a plate. Although, as a sidebar, if you're doing a fungal culture, you should always put a piece of tissue, plant it, because filamentous fungi, particularly the aseptate or pauciseptate, the zygomycetes, they don't like to be ground up because they just lose their cytoplasmic contents. But even for routine cultures, we can grind, homogenize, or mince. I think a lot of larger labs use a homogenizer. It's very, very nice. It's a little bit expensive. I don't know if they're built like this anymore, but we've got one of these stomachers that is, been around since the dinosaurs roamed. It never breaks. We have several of them. They just work and work and work. Tissue grinders are a good option, and certainly if you have bone, you can't put that in a homogenizer, so you should have some tissue grinders alone besides. And then, of course, if you're a small laboratory, you can just use a scalpel and mince the tissue up, and that works okay. It's slow. There's a bigger potential for contamination, but it works. So, media. Well, chocolate and blood are two, in my opinion, must-haves for these type of cultures. And of course, the chocolate agar supports the fastidious organisms, and the sheep blood agar displays the hemolytic pattern. Really, really important. And then many times where there's concern of gram negatives, you want to put in a McConkey or an EMB, and that selects for the gram negatives, and they are also what we call selective and differential, because they differentiate lactose fermenting from non-lactose fermenting. And you may use a CNA or PEA if you're concerned with having a lot of gram positives and you want to pull out gram negatives. What about broth? Well, when I started this, quite a few years ago now, every one of these samples will go into a broth. And it wasn't unusual to get something from the broth only. But as I've cited in this one paper from 1995, studies have shown that things that come out of the broth only are likely contaminant, and they don't contribute to the outcome of the patient. So we don't use it anymore routinely. But that said, there's a good reason to have it. So for instance, the vitreous fluids, you get a few drops. We will just put it into broth. We don't sonicate our hardware, and that's an option that you can do. Studies have shown that if you sonicate hardware, so hardware that's been removed because it's become infected, the sonication process gets that the organism in the biofilm off of the material you've got, and you can culture. But what we do is we'll get the hardware, and it'll usually be in a sage cup, a sterile cup, and we'll just pour in a tube or two of the broth, and then incubate that along, and very often we'll get significant organisms out of that. And we use something, I don't know, I'll just mention this, it's called eugonic broth. How many people have heard of it or use it? Anybody? I'll tell you, we were looking around because we had Dio and we had, tryptic soy broth and we had several different broths. And I came across this Uganic broth, and we've actually been using it for a number of years now. And it's really the only broth I know of that is supplemented for both Haemophilus influenza X and V, but then also for anaerobes, so vitamin K. So it's an all-purpose broth. And again, I'm not didn't get a paycheck from them. I think it's Remel, but it's something you might think about. So anaerobic cultures, and of course, many times the specimens that we're talking about right now, wounds, tissues, and fluids, there's aerobe and an anaerobe culture. Okay, so similar to the aerobic side, you want some selective and non-selective media. Now you have to remember, that you, again, because the anaerobes need things like hemin and vitamin K, is that you want anaerobic formulations. And so you can really use the nutrient agar, the non-selective, which I've listed here. And remember when I say Columbia, that's not CNA, it's the base, Columbia base, supplemented with blood. But of course it doesn't have the nalidixic acid, so it's a general nutrient agar. And then for Bacteroides, the BBE and the LKV, and the obligate anaerobes, the PEA. Now that we started using that recently, a few years ago, and it's kind of interesting because it's somewhat more selective for obligate anaerobes. So a little bit different, I think, than if you use a PEA non-anaerobic formula for gram-positives in your aerobe cultures. I've seen that done. Blood culture bottles can certainly be used for fluids. There's a lot of literature out there that says at least for certain body fluid types, you can use it. Blood culture, and I believe at least with the Bacti Alert, and again, not an endorsement, and I don't know, maybe Bactec now too, has an FDA indication for body fluids. And then there's this thing, pre-reduced anaerobically sterilized media, PRAS media. How many people are aware of this or use it? A few. Okay, so if you look at any of the package inserts from any of these anaerobic media, they'll say, well, you should pre-reduce it. That doesn't mean just putting it into like a holding jar and flushing it. Really, to properly pre-reduce medium, it has to be in an anaerobic environment for about 48 hours. So unless you have a anaerobic chamber, like a gloveless chamber that you can put it in, you're not really fully pre-reducing it. But beyond that, there is the argument, I think some data support that say as soon as media is exposed to oxygen, it develops these oxidative toxins that you can pre-reduce it after, but those toxins remain, and they are toxic to the very most fastidious anaerobes. And so there is this PRAS media, which means that it never sees oxygen. From the moment it's made, it's autoclaved, and then it's packaged. And I would say the best practice recommendation is that it be used, but in truth, I think the gain that you'll get as far as these ultra fastidious anaerobes, in our experience, we use it. I don't think we see any more than when we were just using Remel CDC anaerobe agar, but it is out there. I would say if you're doing anaerobic susceptibility testing, it is important that you use this medium to get, because in our experience we found that we didn't have consistent results till we switched to the PRAS for the E-test, AST. Okay, so talking about the incubation, incubation conditions. For the aerobic side, of course, you need some CO2 for those fastidious CO2-loving organisms. from the most expensive on down is, I mentioned the anaerobic chamber, and it's nice, it's a gloveless thing. It has this airlock here, to move things in and out of the chamber. There's an incubator here, and it's a carousel, so you can put your media in there. You can put pre-reduced media back here, if you so wish. It's very pricey. If you really want to do the, top platinum level anaerobic microbiology, and you do a lot of it, then this is the thing to get. I haven't used this Enoxamat 3. Has anyone used it? Enoxamat? Yeah. And it's, you've had success with it? You like it? Yeah? Okay. And basically, it's a way of creating an anaerobic environment within these vessels or containers. And then, of course, we have the jars and the bags with the anaerobic generators, and that's what a lot of us use. So now what we do is we for our primary meeting, we use the PRAS media, and we use individual packets. And then for our subculturing activities, we tend to just use the regular anaerobic media. And our feeling there is that, out of the clinical material, you may only have a few organisms. You want to really optimize your recovery. So that's why I use PRAS, and then we get it right into these things. The other nice thing about this is that you can take them out and read them right through without having to open them up. You just flip it over and look and see if there's anything growing, and you open it up. Okay. So, question. What do? Do you work it all up? 1 to 2 organisms? Based on, the tea leaves, reading the tea leaves, or some other approach? So let's take a count. Feel like I'm standing there making popcorn on the stove. Slowing down. Okay. Okay, so we have base level of workup on the site sampled, and other information that you have. Okay, that's not what I would have expected, but that's okay. Yeah, and I mean, we don't have time to talk about it, but I'd be interested to see how you operationalize that. Although, well, depends on how deep you want to go, sterile and non-sterile, or do you go past that and even more selective? But there's no really right approach. So I think, regardless of how you decide what is important, what are you going to work up, what are you going to do susceptibility on? It's really is, have some data-driven plan on, how you determine what's most likely significant. And really, the thing we don't want to do is always work up everything, and I do remember that, and it was a big headache, and we felt, as microbiologists, we want to do it all. And that's how it was when I started out in the 80s. I mean, we just worked a lot of stuff up. You want to do the identification of the susceptibility of the clinically significant isolates. But you also want to make some commentary, I think, and these are my opinions and my co-contributors, some information about the commensal flora that's there as well. I don't like to say normal flora. I've had pushback on that because what's normal? I think it's more useful. We break it down into, if it looks like respiratory or GI or urogenital, and we've had some techs have said, they'll have something above the diaphragm and culture some site and it's got, GI flora or something. It's like, well, there's something, could be something going on there, fistula or something, or you don't know. Just tell it like you see it. And, this really, as I said, I won't go through the bullet points, but I really think having this directed approach, I don't think there's a right answer, but having some directed approach is the much better than just culturing a lot of stuff, working it up. Okay. Of course, there's the conundrums, right? Sterile body fluids versus wounds and abscesses. We don't know. You get something in a syringe, and you might look and say, well, it's pussy. It looks like an abscess, where it's clear. And again, we've already talked about trying to optimize the information you get with that culture order, to be more specific about what it's from. Tissue isn't all the same. I think it's easy to say, oh, it came out of the OR. It's got to give it a full court press. Whereas, no, my personal feeling, the way I've trended more is like if it's a wound, if it's from arms or legs, an appendage, versus a true deep, biopsy of lung or, deep organs or brain, then there's different ways to work that up, and I'll talk about that. But it is, it's challenging to know what you're really dealing with. I would say, as I've already talked about it, is the EMR is really very, very useful, which has helped us. I'll come back as being able to look at it, and you don't know. What's the acuity? Is it superficial? Is it deep? It may get the same body. It may get the same description in the in the culture order. Can't differentiate. So we have to work with what we get, right? We're going to get swabs, but as we've talked about earlier, are there PMNs? We round every day in our laboratory, and maybe me or the other doctoral scientist and microbiologist, and that's the number one question. There's Dr. Novicki, should I work this up or not? There's only a few of them, and it's only on one plate, and what's the Gramstein show? And I think is again, I just mentioned this a moment ago. I broached the subject. Is the EMR. We have encouraged our techs to use the clinical side of the EMR, and they don't do it in any deep way. But we just say, if you don't know, is it superficial, deep? Is just find the doctor who ordered it and the date the culture was collected, and look at their note. Did the patient come in because they have this flaming lesion on their abdomen? Or did they come in because they're uncontrolled diabetes and they said, oh, doc, I got this little thing here, let's culture it. It's very easy for techs to figure that out by just using the EMR. And then certainly, encourage your techs to talk, for the more upper level people in the audience is, encourage your techs to actually consult. And like I said, we go out in the morning and then we go out in the afternoon and say, hey, what's going on? And our techs will give us this stuff, and if they weren't able to find it out or they're too busy, we just walk over and pull up that EMR. And we also, many of our techs are comfortable with calling the docs, the ordering doc. Hey, doc got here, what do you think? What would you like worked up? My experience has been, and it may differ from institution to institution, but my experience has been that is, don't call them at 3 a.m, but during normal working hours, they're very appreciative that they're getting that extra care, and they're willing to work. So if you don't do that, use the EMR, encourage your techs to talk to the docs. It'll get you some of that information that, consider doing, because it'll get you that information that we don't get. So I'm going to tell you our approach. And so, and it's not right or wrong. It's come a long time developed. But basically, we split it into, sterile and non-sterile. And of course, if they're culturing it, it's got an infection, it ain't sterile. But what should it be normally? So you have your normally sterile sites, the body fluids, the deep tissues, hardware that's been removed, versus all these other things. And it goes, 1 to 2 organisms, greater than or equal to 3 with 1 to 2 predominant, or greater than or equal to 3, no predominance. And if you look at, this, the stuff in white is the same. And we always try to get Pseudomonas, Staph aureus, and beta hemolytic strep. And recently we've started ruling out Candida auris too. We haven't found any, but we do an ID on our yeasts. But the difference is that we go a little bit farther. We'll say, we'll give some descriptive, on the sterile side, we'll give some descriptive listing of that subordinate stuff versus, on the dirty sites, it's just commensal. And then similarly here, we'll give, some listing up to 5 morphs. And then otherwise, we call it on the non-sterile. And this has worked out really, and again, this is what we do in our lab, but it's worked out well for us because if you miscategorize, you're still likely going to get the important stuff. So I asked that question before, is like, do you work up everything the same, or do you base it on various criteria? This is really the only criteria we use in our lab, and it works. It's practical, but it's it's not gospel. I do think it's important that you look for some of these things, and the important thing is you can see them in a mix, or you can smell it in the case of a rouge. There might be some other important things, but you're never going to find them buried, when you've got a lawn of bacteria. As I mentioned, we do surveillance for Candida auris. We haven't found any yet. And regarding a rouge and Staph aureus and BHS, there's no heroics. If we think it's in there, we'll try to pass it, pull it out. But if we don't get it, we don't get it. The techs look at the gram stains a lot, but they really rely on it, as I mentioned, with the cases where it's not a clear cut. You may get pure culture of Staph aureus, like you don't need to look at the gram stain, right? It's more mixed. It's like, maybe I should, maybe I shouldn't. Let's see what white cells are there. And I've already mentioned the EMR. Encourage your techs to do that. Techs call providers, and then you as managers and directors of the lab, get out there, and I'm sure many of you do, and encourage your techs to, get some input, and maybe you make that call. When do you want to finish up, Aaron? Huh? Yeah, okay. So, again, fluids are not fluids, and we need to think about, you have those cleaner fluids, and then again, we don't always know, but certainly in the realm of the synovial pleural, the CAPD, pericardial amniotic fluid, those should be sterile, and they should be treated accordingly. Whereas, pleural fluids that are coming out of a chest tube, or, G-tubes, peritoneal, bile fluids, those, in some cases they should be sterile, but obviously if you're getting them, if there's a drainage tube in, there's some infection there. And, I certainly would, you're probably going to find those are growing a lot. That's kind of the beauty of that setup that we use in the lab is, if we misclassify it, we're probably still going to get the 1 or 2 significant organisms. But this is the way we look at at fluids. So more of an aspirate versus a drainage. Now, anaerobes, okay. I should have put this up there. How many labs, let me say that, how many labs do aerobe cultures but not anaerobe? Aerobes, okay. So you would send your anaerobes out to reference labs, okay. So from one of my co-contributors, I don't know about your lab, but in my lab, this is everyone's least favorite time of day. They're stinky, they are more often than not messy and complicated, and the process is slow as molasses. So, why are we interested in anaerobes? Well, depending on the body site, they may be rare or they may be the predominate. So in the GI tract is 99% anaerobic bacteria. And some of them are aerotolerant, like Bacteroides. They'll survive exposed to oxygen. They won't grow. Others are very fastidious. Exposed to oxygen and they die. And as with aerobes, they're opportunistic pathogens of varying pathogenicity. So, just to be clear, when I say an anaerobe, we're talking about obligate anaerobes. Again, these are the things that will not grow in the presence of oxygen. Many species of Bacillus, they are strict aerobes. Many of the bacteria we deal with, as you know, are the facultative anaerobes, but we call them aerobes, meaning they can grow with or without oxygen. So anaerobe, obligate anaerobe, facultative anaerobe is the aerobe. Then, of course, you've got your microaerophilic and your capnophilic as well, and those can show up, in various places depending on their preference of more or less oxygen. Anaerobic infections involve aerobes as well. Now, and I'm using those, obligate anaerobe and facultative anaerobe, actually anaerobe and aerobes. They, and in fact, it's been shown that particularly on the anaerobic side, it's a symbiotic kind of a process, using each other's metabolic products and so on and so forth. And we tend to find them in the mucosal surfaces, and so anaerobes can be a part of the infection process in many places. More kind of internal and in some contact with these mucosal surfaces and GI tract, GU tract. So here's a question for you that's come up: is how many of you work up your aerobe and anaerobe cultures on the same specimen at one bench? Or how do you work it up? Do you one bench works up both, together at different times, maybe because you're a smaller lab, or you just you separate them, different benches? So let's take a count here. Okay, interesting. Yeah, almost half worked them up together. Yeah, good. And so this is something that we're actually going to bring into place, and I'm interested to see almost half of you are doing it already. But it makes a lot of sense to work them up together. Particularly think about the fact that the aerobe side gets done quicker than the anaerobe side, and if they're not being worked together, if you had worked them together, you realize holistically that they may not have a significant organism. So, like for instance, let's say the gram stain shows 3+ PMNs, 3+ GNB, and 2+ GPB. The aerobic culture has a 3+ lactose fermenting gram-negative bacillus and 3+ coriniform GPBs. The anaerobic culture, I should go back and say, well, you look at that, if it's the aerobe bench is working up this alone, they're going to say, well, that's significant. But, depending, now this is like from a wound or something like that, or an abdominal culture. Now, the anaerobic side, they find, a lot of anaerobes. And now you look at this culture and say, well, you know what? It's a mix, And again, you could see this like in an anaerobe, in an abdominal culture, or a wound culture is like, so working them up together, you're more likely to recognize this and not report something as significant when it isn't. Of course, it takes more bench training, and we treat anaerobes as a specialty in many labs. But what one thing you can do is you say, the aerobes and anaerobes travel together to the anaerobologists. And then the aerobe cultures, or there's just an aerobe culture, that can go to the more, the lesser trained generalist tech. And so how would you do that? Well, so for day one, if you're looking at them together, you're going to see some E. coli, some Corynebacterium JKM, and mixed skin flora, and say, well, I think I got some significant stuff there. But then, as you're looking at the anaerobe, you see that plate. You're not maybe going to work it up. You're going to let it grow for another day. They would say, oh, I see a lot of stuff going on. So I'm not going to pursue that aerobic stuff. And it leads to a lot less work. And I would say, too, that, I think the MALDI-TOF has led to the anaerobe bench being a lot less of a specialty bench. That's been our experience. We do a lot less aero tolerance testing. And so that only makes more sense to facilitate, working them up together. I think that's a really great idea if you're not doing that now. Okay. This is something I'll share with you, and it's interesting. It's out of the Clin Micro Procedures Handbook. And so it's a very abbreviated approach. Now, it's not for everyone, but it's certainly something you can consider, and your docs would have to be on board with it. And I won't go through the whole thing. I can get this slide to you. Aaron, do we have these on?
They will be posted.
They'll be posted, yeah. Yeah. But basically, you start with gram stain, and you paint with, brush, broad brush painting strokes here. And then you're grouping organisms, or saying you're ruling them out. And I think there's some data to show probably that this is sufficient for managing anaerobe cultures, particularly I would say ones that come from non-sterile sites. I think it's interesting, I think there's some data to show that if you eliminate the aerobes, anaerobe kind of clear up as well. So maybe not giving the full cord press to the anaerobes is acceptable in some cases. Okay, again, we don't want to be susceptibility testing and everything. Physician sees a antibiogram report on an organism, they feel, well, the microlab thought it was important, I better treat. You should, another, from an antibiotic stewardship and patient care, you should choose the best drug panels. You've got a Vitek card or you've got a microscan card. Don't report every drug that's on there. You want to facilitate with the so-called cascading. So, you're starting out with a narrow spectrum. So if you have an AMP susceptible E. coli, don't report out the ceftriaxone and the cefepime. And certainly, you want to follow the guidelines if you're doing the manual AST. And so that would be the CSI M2 for Kirby Bauer and M7 for MIC testing. And work with your stakeholders on picking those panels and figuring out the cascading. We have a really good anti-infective PharmD, and we sit down with him now every year and go over these panels. And it might be ID docs, it might be a PharmD. Don't do it in the isolation in the microlab because we don't really know it all. I'm not going to go through this, but just be aware the CSIM 100, which comes out every year, has this table 1. It was already shown earlier. And basically, for each group of organisms, it used to be category, now it's tiers, but it's basically always test and report. If you have resistance in this here, then always test but report selectively, and they're kind of boxed together. And then you may have special anti-infectives. If you have a very resistant Acinetobacter in your ICU or something like that, you'll find some drugs here. And then maybe some other drugs that your ID docs prefer and are known to have some activity against the organism. So this would be your foundation when you sit down with your stakeholders and go through these tables and review your panels. Okay, we're on the end, the final run here. I want to talk about 2 things. Wound healing cultures is one of them. So many of you may have, docs who do wound healing. These are very often people who are diabetics, and they are, foot wounds, but other, there's other, causes of these non-healing wounds. The take-home message is they're not acute wounds, and the ID docs will argue, I've seen it with the wound healing docs saying there's no white cells, you don't have an infection. And I think in this regard, the IDSA, the Infectious Disease Society of America, has blinders on, because there's a lot of data there now that actually shows that there's a different pathophysiology or pathobiology going on in a non-healing wound. So what's happening? Well, it's hypoxic, there's no oxygen, there's no inflammatory response, the vascularization, there's no inflammatory cells, and the biofilm is quite well developed. And this biofilm actually it manipulates the local tissues, it manipulates the immunity, and it prevents fibroblast deposition, scar formation. And there's certain bacteria that are more related with this than others. And if you look at the best practices for dealing with this is quantitative cultures, because there's a good correlation again between the bacterial burden and the ability of that wound to heal or not. Now, our wound healing docs never asked us to do this, but in other places I've been, that we did quantitative cultures on these. There is quantitative next-gen sequencing, which is coming, and we may see it at some point. But I will just point out this paper. If your docs have got, your wound healing docs have got you doing the quantitative culture, there's this nice paper here which found a correlation between our standard 4-quadrant streaking and the quantitative, fully quantitative burden. And so you can just do your 4-quadrant streaking, and they can get very good predictions from, is it, +1, +2, +3, or +4. The second one is multiple surgical types. Okay, is it legitimate? And can we combine them? We'd love to combine them. We get that 4, 5, 6, 7, 8 from the orthopedic surgeon. Well, no. And why is that? Well, because most of the time when you're getting those multiple samples, it's prosthetic joint infection. They're resecting that joint. They're taking it out, that artificial joint. And it's often caused, again, by skin organisms that got into that site probably during surgery or shortly thereafter, and then they're just percolating along for weeks or months. And so, you can't just say, again, it's the old question of coag-negative staph. Is it significant or not? Cutibacterium. So the literature, in the orthopedic literature, shows that if it's, again, like blood cultures, if it's present in more than 2 samples, it's probably significant. It's not something that we got on the surgery when we collected the specimen. And 5 to 6 have demonstrated the maximal sensitivity, because, the microbial burdens are very, very low in these prosthetic joint infections. So we just got to suck it up, and we have to do it. But, in this paper here, 5 to 6 for maximal sensitivity. So if you've got someone who's, going more than that, you might want to have a conversation with them, and this would be a couple papers to start out with. So we've already seen this. If you don't have these 2 texts in your lab, I highly recommend that you get them. They're wonderful. Just a huge resource. Manual of Clin Micro is more, clinical, characteristics, treatment, and then a lot of other information too. And then the Clin Micro procedure handbook is, best practice, how to do it. And that's it. So if you got any questions, I'm open.
I just wanted to ask a question about the prosthetic joint infections. Oftentimes when we receive our series of 6+ cultures, they're also ordering the AFB and fungal cultures. And is that something that happens in your lab a lot, or do they narrow down the AFB and fungal cultures to just 1 or 2 of those specimens?
Yeah, in the case of those prosthetic joint infections, I think they tend to go after aerobes and anaerobes, so I can't really speak to the other organisms, they might order it, but my feeling is it's not a big problem. Is it in your lab?
It seems like every time we
do
get a
it.
series of those, that we get the same amount
Yeah.
of orders for the AFB and fungal cultures. And we're having a hard time backing up,
Yeah.
do we really need that? Are we wasting money, resources, et cetera, for the
So
other
there's
specialty
some-
cultures?
Sorry, there's some good data about the mycobacterial cultures and benefit of pooling for those samples. So we did move to this in the past couple of years at the state lab to start pooling our mycobacteria cultures because the number of organisms is incredibly low. And if it's there, it's there. It doesn't matter if it's in 1 out of 5 or 5 out of 10, it's still going to be treated if they find it at all. And we've also found that by pooling them, because of the decontamination procedures we put these through, often it gets concentrated. So you're even more likely to pick it up by stains or culture methods than if you were doing single samples, separate cultures for each individual one. So our procedure is to automatically pool. We get 3 or more from the same surgical site.
That's great information, thank you.
Hi, I just had a question about the diabetic kind of foot wound cultures they were talking about. So in those situations where they're wanting more of like a quantitative like burden, like bacterial burden, is that more of just like lump it all together, or would they be looking for ID and AST on those types of samples too?
You know, I'm sorry, I can't answer that because I don't know that offhand, but I think you could find the literature. I don't know the process that well. Like I said, I did it, but it was a long time ago. Yeah. Is anyone else doing the quantitative wound healing cultures? It could help with that. Yeah. I would say look at. Have you looked in the Clin Micro Handbook? Might have it in there. Yeah. Yes.
So I was wondering with with bringing up the fact that getting it plated in a timely manner, like less than 4 hours, or same thing with like respiratory specimens as far as being able to recover H. flu, strep pneumo, and with how to balance that with the move to the automated systems, because when we switched to an automated system of automatic plating, all of the RRLs stopped setting up their own cultures. Everything got sent to us. So they were not being plated in a timely manner because there was delays in courier transport, then, receiving them in, and when they finally get to us, and especially if it's a weekend where you have less couriers going, it can be a good 12 hours before we get specimens.
Yeah,
So how
yeah.
do we kind of balance that with the push towards more automation?
Well, I don't think you can. It's an accepted limitation, and we deal with outreach clients too. I think you have to do the best you can. Work with your couriers to make sure that specimens are being transported. You can even do things like, we had a problem with our couriers because our outreach or our outpatient clinics, they were, other than urgent care, they weren't open Saturdays and Sundays. So, the courier might come at 2 p.m., but they're collecting on a Friday, they're collecting samples. So we worked, just to shift our courier to make sure that it was at the end. That's a best practice. If someone has an infection, common things being common, they're probably going to survive in that. But you always worry about, the fastidious things that aren't going to survive. And then, specifically, I don't know if anyone, I'm just off the top of my head, doing Neisseria gonorrhea cultures still. Well, you look at a molecular test in those situations. And again, I think that's probably pretty rare these days. But, for those fastidious ones, the mobile incubators work very well for us. It's a fact of life, just try to optimize your practices.
Thanks for your presentation. I have a question about that correlation of semi-quantitative wound healing cultures versus the traditional quantitative. and I apologize if I missed if you said this before, but in your review of your literature, did they come up with a 3+ or a 4+? What is significant in something like that? Did they make any mention of what's significant, especially in the context if you're grabbing normal commensal, as you like to say, flora, along with your tissue?
Yeah.
Do you have any sense of how that works as far as if a 3+ is significant or a 2+ or a 4+?
Yeah, generally, I don't remember the numbers, but the way the paper worked is that, they said, okay, because it's in the literature, it's pretty well defined if you're doing the full quantitation, so it was basically they plotted the full quantitation this way, CFUs per ml versus, 1, 2, 3, 4 quadrant, and they just were able to draw a nice straight correlation line, but where it lined up, I think it was 3+ and above. I mean, if you look at the paper, they explain it. When it came out, last year, I read it. I don't have it all up here, but it struck me as it was a reasonable approach to full quantitation. I thought the data was pretty good. Yeah. Yes, Ray.
On those prosthetic joint tissue cultures, we put a process in place to incubate those in blood culture bottles. And there's a lot of good literature on that process. And so when you incubate in blood culture bottles, you need only 3 or 4 separate tissues instead of 5 or 6. Mm-hmm. And when we were doing our validation, I think we found 17 more significant positives growing them out of blood culture bottles than we did doing it the traditional way. I think a lot of people now are really into sonicating, taking the implant out, sonicating it and doing all this. Well, we can't do that. But these blood culture bottles for those tissues, they work really nicely. Then you just put them in the incubator for 14 days and let the blood culture instrument watch them.
Yeah. Good. Thank you, Ray. I have a question for you is, so I'm familiar with the BACT-Alert, and they have an FDA indication for body fluids. So how did you approach that, from a regulatory or a scientific validation standpoint? I presume that you're homogenizing the tissue and then
we're grinding them.
Injecting it in.
So we did. At the time, we used the BACT-Alert now and the Virtuo now, but at the time we used BACTEC bottles, and we just did a verification. It took over a year to do that. Okay. And then when we switched over to the BACT-Alert bottles, we just did a mini validation with it since we had already cranked it out. But it took a long time, but it's, I feel, really does as good a job as we can do short of sonication using the bottles.
It makes sense. So has this been published, or did you
there's a lot in the
do that de
literature about
novo?
it. There's a lot in the literature about it, using blood culture bottles to do these prosthetic joint infections. So there's a lot in the literature.
So work up front, but then going onward, you're saving because you're not working up all those plates.
Correct. Yep.
And they're getting maybe charged less because it's not 5 or 6, it's 3 or 4. If I understood you correctly.
I don't know any. We take what they send us. And everything.
Yeah.
But it's worked again. Like I said, we recovered organisms from a number of specimens when we did the validation that didn't grow anything conventionally.
Oh. Thank you, Ray.
Just a quick question on anaerobe cultures. When you were talking about combining the results that you have on both the aerobic and the anaerobic cultures and then deciding what you work up or don't, what about the situation where we have it? Usually our aerobic culture, if it's a good collection, we may have the results out within 2 days. But our anaerobes, we hold in the bags. We use the anaerobe bag system. We hold them for 3 days before we open them. So by that time, we may have verified 2 up to 3 organisms on the aerobic culture based on what he saw on the smear or what the doctor wants. But then your anaerobe culture, all of a sudden, you may have seen through the bag there was a black pigmented bacteroides, whatever, but you haven't confirmed how much in there is anaerobic.
Yeah.
And let's say now you got 4 in there, so how much work do you do on the anaerobe now? Because you already got maybe a total of 7 altogether if your 2 cultures were being worked in tandem.
Yeah, yeah. No, that's the problem, and exactly. And I think, like I said, I think that's the value of having one tech have aerobe and anaerobe in front of them, and by that, and I'm saying, I'm saying this just, theoretically because we're going to move to this. But I know a lot of labs are doing this, and maybe they can answer this question better than I can. But when I think about it conceptually is, okay, on day 1, you look at the aerobe plate, and you've got, a couple of things that you say, oh, I got to pursue this. Well, if you have the bag and you look at that anaerobe culture, and you can start to see the haze, and you say, well, you know what? I think this is going to be mixed. I might want to stand down. I'm just going to subculture if I need to, that E. coli and that Enterococcus. And then, and we look at our anaerobes, except on the weekends, it's Friday to Monday, but then during the week, it's, we give them 2 days when we'll open it up. So I think that's where the value, you kind of, you get an idea what's going on there.
I can kind of answer his question. We don't. We have aerobic and anaerobic. We do the exact same thing that you do. Those bags don't get opened for 72 hours. So we work up our aerobic side, and then our anaerobic is completely separate. Most of the time, if we have anaerobes, we will work up a predominating one, but we don't quantitate. And then if we have more, we call poly. If you have the same organisms as the aerobic side, we say no anaerobes isolated, so that there's those anaerobic side are not combined. Yeah. We've already gotten our pathogen, so anaerobes most of the time, treatment's the same anyway, so we don't really go down that rabbit hole. So, but it is on the same bench. Works very well for one tech to be reading both at the same time. Yeah. So I thought that was clinically significant. So we don't separate those.
I think if you decide to start working the aerobe first, I guess regardless if it's 1 bench or 2, like what we do now is, we use the aerobe to inform working up the anaerobe. So, we'll look and say, oh, they got 2 or 3 things out of the aerobe. Well, it's been reported, the ID's out, the susceptibility are out. But then we'll look at the anaerobe at least, and we'll say, and there's 3 or 4 things, and it's like, okay, and we don't even do the aero tolerance testing anymore. We'll just say, this is, a mix of, bacterial organisms. We don't say anaerobes because we don't know, we didn't do the aero tolerance, but we just say it's a mix. And that's really conveying, the information that, this culture's got a lot of things in it. So the aerobe has been worked up when we don't retract that, but at least it informs you on the anaerobe side. Yes?
When we compare the cultures, the anaerobic culture with the aerobic culture, we do that on the 2nd day read. So we've already worked up our aerobic culture that first day of the read, and we're opening up the anaerobic culture after 48 hours. And then a lot of times when we're looking at that, we can rule out, well, this anaerobe culture looks like it's growing Staph aureus, beta hemolytic strep, and we can rule those out. Before we got moldy, we were doing aero tolerance testing on all that stuff, so that rules that out. We don't need to do the aero tolerance test on that, and that's the reasoning for comparing those 2 at the same time.
Thanks, Meg. All right, well, once again, thank you.